Thank you. Good morning. Can everyone hear me okay? All right. It's working through the mic. All right. So just by way of introduction, first of all, thank you very much for inviting me in to share some stories with you. I work with NTCA, the Rural Broadband Association. We represent about 850 locally operated, community-based telephone/internet service providers in rural areas throughout the United States. These are companies that began as telephone companies in the first half of the 20th century in places where the Bell Company wouldn't build out. It just wasn't worth the Bell Company's business model to go to a town of 5,000 or 6,000 people. So there used to be thousands of these independent companies, or about 1,200 left. We represent about 850 of them in our organization. Despite their small size, on average 35 employees, on average about 5,000 residential and business accounts, they get fiber to the prem to nearly 90% of their locations. So when we talk about what this means for rural areas, and particularly perhaps rural areas that don't have that broadband connectivity, we're really getting into the art of the possible. And Catherine said this is a storytelling exercise, so we're going to start with a story about health, a story about hope, a story about renewal, but most of all, and most importantly, a story about community. So picture this: you served your country, perhaps in Korea, or Vietnam, or Desert Storm, and you live in McKee, Kentucky, which has a population of 774 people at the last census count. Your closest access to specialized care is an hour away. And we're talking about communities where there's really no such thing as public transportation unless it's a church van that happens to be available during the week. And now imagine your doctor says, we can help you manage all of your medical issues, whether it's diabetes, high blood pressure, perhaps mental health needs. We can help you manage these issues through video calls and other connected technology, perhaps a connected stethoscope or otoscope. But you spent a lifetime in the workforce before computers and broadband were a thing. So the idea of visiting a doctor over the internet is about as foreign to you as the places to which you were deployed. And this was the reality for thousands of rural veterans in 2017. And this is a story of how a simple idea, creating a living room in a library, became a lifeline. All right, one of these buttons should advance the slide, so we're just gonna, here we go. Go back. Oops. So rural America faces a healthcare crisis, and I'm sure that this is something which everyone in this room is aware. But a lot of people never see it. Just under 14% of Americans live in rural spaces, but over 2/3 of all healthcare provider shortage areas are in rural counties. On average, rural Americans have higher incidences of diabetes, heart disease, substance use disorder, and chronic pain. And the Veterans Administration, or now the Department of Veteran Affairs, reports that 50 to 70% of rehab patients do not receive treatment because there are travel barriers, or missing work, caregiver duties, or lack of access to specialists in rural areas. And rural veterans in these communities face a double burden because they're older, often uninsured, and dealing with service-connected conditions that require specialized care. Now, here's the kicker. The Department of Veterans Affairs had already addressed not only the healthcare problems, but the access problems by creating one of the most sophisticated telehealth systems in the world. Veterans could access mental health counselors, specialists from anywhere, so long as they had broadband and know how to use it. So the VA had the tools, but we just needed to figure out how to get people to use them. We had a moment of connection in 2016. The White House Rural Council gathered a national rural health convening. Government officials, doctors, broadband providers, all trying to solve the puzzle. But the real breakthrough came after the formal meeting ended. The VA told us that they had warehouses of telehealth equipment that was sitting unused. Mostly iPads, a lot of specialized devices for monitoring and sensing, but what they didn't have was how to bring those devices and connect the last mile. And that last connection, and as I mentioned, we've had the broadband connection, but it was the human connection that we needed to figure out how we could bridge that gap between veterans and life-changing healthcare. And that's when a handful of rural broadband executives stepped forward. And this is them. They're not Silicon Valley entrepreneurs. They are not healthcare moguls. Doug to my left is in Iowa. Tom is also in Iowa. You've got a few guys in Kansas in this picture. But these are all men who either served or who have direct family in the service. And they came to the VA's Office of Rural Health and said, we have the networks, we have the relationships, what can we do? And the result was a bit counterintuitive. Instead of bringing technology to veterans, we brought veterans to the technology in a place where they already felt comfortable. So picture walking into something that looks like your living room. It's got comfortable chairs, warm lighting, maybe some pictures on the wall, but in the corner, there's an alcove and it's soundproof and private with cutting-edge telehealth equipment, cameras, monitors, medical devices that can check your blood pressure, your blood sugar, and transmit the results instantly and securely to a doctor who may be hundreds of miles away. And we called this the virtual living room. It's not a sterile medical facility. It's a space intended to replicate a veteran's living room where he or she might otherwise access telehealth comfortably and privately as if they were in their own home. We placed the first one in the Jackson County Public Library in McKee, Kentucky in 2017. Again, McKee, population of 774. But the technology and the secure soundproof room were not enough. And this is actually the interaction space. We needed and recruited people who we called digital shepherds. And these were librarians and workers from the local broadband company down the street who helped veterans navigate unfamiliar technology. And the results were immediate. Veterans had ready access to VA general practitioners and specialists. Counseling became accessible without stigma, because no one knows if I'm parking at the library, especially in a small community. Nobody knows if I'm parking at a library to drop off books. And when I enter the virtual living room space, no one knows whether I'm going in there for a consult on diabetes or high blood pressure, or whether I'm stepping in for a mental health consult. We placed more virtual living rooms throughout the country. But as smartphones became more prevalent and broadband adoption increases among older Americans, something unexpected happened. Veterans were now saying, I can just use my phone, or I have a computer at home. So the very success of the virtual living rooms was making them less necessary for their original purpose. One Gulf War veteran said, I just use my smartphone now for telehealth appointments. And we looked at this and we said, this isn't failure. This is evolution. We created bridges and people learned how to cross those bridges. And the virtual living rooms are still there because the VA has so many other online services for benefits, employment, and other support, and we still have veterans to serve. Today, we have deployed these virtual living rooms across the country. We have them in Kentucky, Vermont, Tennessee, South Carolina, Nebraska, Alabama, Kansas, in locations as diverse as public libraries, VFW halls, American Legion posts, and shared office spaces, and they're still serving communities. They're still serving telehealth needs, but their use has expanded in ways we didn't expect. They're being used for GED testing and continuing education, General telehealth appointments still occur for non-veterans as well, and community meetings. One of our sites tallied more than 2,000 people using one location last year. And this is what we learned. When you create a space that is designed with accessibility and community in mind, it serves needs you never anticipated. What we like to say that the infrastructure of care became the infrastructure of hope. Now, from the VA side, they're still pushing the envelope on healthcare, and they actually have a full team dedicated to researching and piloting virtual reality healthcare. As of this past Wednesday, because I spoke with the person who leads this effort, the VA has deployed VR headsets in more than 170 locations in all 50 states, as well as Guam, American Samoa, and Puerto Rico, involving more than 3,000 frontline staffers and serving more than 10,000 veterans. These are not experiments or trials. They are pilots deploying evidence-based tests on a widespread basis. And they are exploring VR and immersive reality for applications like cardiac rehab, group therapy, post-surgical rehab. And along the way, they're gathering the data on everything from patient comfort to technological capabilities to cost modeling to the mitigation of barriers that might otherwise impede access to healthcare in rural spaces. And one point that I find incredibly interesting is that the VA notes that the cost of citing the virtual reality healthcare equipment is in most instances far lower than the traditional medical equipment that it would replace. And as these data emerge, I think it can offer some information that can be very attractive to rural hospital CFOs. So our work is still not done, even with the virtual living room placement. Rural healthcare challenges persist. Veterans are still underserved. And what we're learning is that the lessons of the virtual living room isn't just about veterans or rural healthcare. It's about meeting people where they are, literally and emotionally, and recognizing that the most sophisticated technology in the world works best when it's safe, warm, and welcoming. Because a lot of times the best thing we can say about technology is, this fits you, let's help you use it. So that brings us to some core issues and lessons that we've developed from this. Digital literacy, technology selection, staff training, and outreach. So as I mentioned earlier, we have digital shepherds, volunteers and staff at the libraries and the VFW posts and the local broadband companies who guide users through unfamiliar technology. Digital literacy and broadband adoption gaps are closing, but as technology continues to advance, there will always be a gap between the proficiency and comfort of older users who are not used to the technology as opposed to younger users or early adopters. So finding a way to train the trainers will always be one of the most valuable investments. In terms of ease of use, I would prioritize ease of use over capability. It does not have to be a broad margin, but technology that's too complicated and sits unused won't have that benefit. So sometimes sacrifice a little bit of the cutting edge technology and work for something that can reach the broadest audience. And then the most important thing is that you know your community better than anyone else. We can have the brightest doctors, the most brilliant technologists, the most innovative app developers, but the magic happens when users embrace the technology. So you know your community and you can help make those connections. And then finally, in terms of resources, the virtual living room does not require a ton of resources. What we have found is that the host sites usually contribute the space. The rural broadband company member of NTCA usually contributes the connectivity and the service cost. Volunteers and vendors and shop owners from the community usually donate the materials, the paint, the furnishings to rehabilitate the space. And we have grant funding available that can cover the lion's share of the telehealth equipment that goes into these rooms. The virtual living room worked and continues to work not because it's high tech, but it's really because it's high touch. It takes into account the demands of those individual local communities. It brings the local people together, and it creates that safe and welcoming space for its users. For more information about the virtual living room, I invite you to visit FRS.org, Foundation for Rural Service. It's FRS.org. And I've also left on the registration table some reports that we have produced on use cases for extended reality platforms in rural telehealth. So I want to thank all of you, and thank you, Catherine.